Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture series, we're going to go through the entire nursing pharmacology curriculum, starting today at the very beginning. So in this video, we're going to go through the introduction or the fundamentals of pharmacology. Let's get right to it. First, we're going to begin with the different routes that are available to administer medications. We begin with the parenteral routes. Parenteral routes means around the GI system, meaning any route other than what goes through the GI system. Parenteral includes IV, intravenous, into the vein. Sub-Q, subcutaneous, it goes into the fatty layer of the subcutaneous. IM, intramuscular, goes into your muscle. IO, intraosseous, it goes into the bone. Buccal, that's where we place it on the side of inside the mouth between the gum line and the cheek. So it goes inside the cheek. Sublingual is where we place it under the tongue. Rectal, obviously, is where we place it in the anus. Vaginal is where we place it into the vagina. We also have a few more. We have transdermal, which is where we take usually a cream and put it on the chest or some other part, and then we put a Band-Aid over it. Or more commonly, we have medication-infused patches, such as fentanyl, where we just place those patches on the patient, and then that becomes transdermal. We have inhalation, where the patient breathes in the medication, such as albuterol. We have topical, where we put a cream on the patient. I don't want you guys to get confused. Transdermal and topical are both placed on the skin, but transdermal is formulated to go through the skin, get absorbed into the sub-Q, into the muscle, into the blood, and it goes into central circulation, as opposed to topical is formulated to just have an action on that local area where you place the cream. Intranasal is into the nose. Ophthalmic is into the eye, otic is into the ear, intradermal is into the skin. The most common example of an intradermal injection is the TB skin test. Next, we have enteral. Enteral is where we do put the medication into the GI system. So that's where we have PO, which is by far the most common route of all medications administered is going to be PO. Even though in the hospital setting, we do use a lot of IV, PO is still number one. We have NG, nasogastric. OG, orogastric, that's where we put a tube down gastric into the stomach, and the tube can go either through the nose or through the mouth. That would be NG or OG. And finally, we have ODT, oral disintegrating tablets. That's where we put the medication on the patient's tongue. The most common example of that is Zofran, which we'll learn a ton about as we get to that lecture. Zofran is a medication that's ODT. We put it on the tongue. It just dissolves into the patient's saliva. As they swallow the saliva, they get their medication. We also have two other terms I want you to be familiar with, IV push versus IV infusion. IV push is where you draw up a medication in the syringe and you inject it into the patient's IV. As opposed to IV infusion is where you're hanging, that's the language we use, it's hanging a medication and it's going into the IV, but it's going via an infusion. It's not just a one-time push, it's an IV infusion. An IV infusion is usually run over 20, 30 minutes, an hour, 2 hours. It could be a continuous infusion where it's running for days, but that's an IV infusion versus an IV push is where we're just injecting the medication directly into the portal, and that can be done usually over about 30 seconds up to about 5 minutes, depending. Generally speaking, we don't ever slam a medication in. We always give a very, very slow push on a medication. Generally, the rule of thumb is it's safe to give pretty much any medication over about 1 to 2 minutes. Your book may tell you somewhere between 30 seconds and 5 minutes. All of that is correct. There is one additional term I want to cover, and that is IVPB, IV piggyback. And IV piggyback is where you have a secondary infusion going in addition to a primary infusion. Only one of those is infusing at a time. You'll learn more about that when you get to hands-on skills in the clinical setting or in the skills classroom. Next, let's talk about parenteral. Will almost always have a quicker onset versus enteral. In fact, I think I could say always. Parenteral will always have a quicker onset versus enteral. Parenteral, again, is around the GI system versus going through the GI system. Next, let's talk about IO and IV, because every medication is going to be labeled for which route it can be given. You can't just take a PO pill and give it vaginally. There's no such thing. It has to be labeled for the specific route. However, any medication that is labeled for the IV route can always be given via the IO route, and there's no other rule like that. But IV and IO are completely interchangeable. That being said, the vast majority of medications will say IV/IM because a lot of them can be given via the IM route. However, that is certainly not all of them. There are tons of exceptions to that, but IV and IO are interchangeable. Many routes are able to have systemic effects. There are a few that do not, such as topical, otic, ophthalmic. Next, I want to cover extravasation. Extravasation, also known as infiltration, is where an IV, where you're giving medication into the patient's established IV. And remember, IV is intravenous, into the vein. But if the IV infiltrates, what does that mean? That means I have an IV here in my hand, but the IV tip is no longer inside the blood vessel, or that blood vessel popped. So now the medication, instead of going IV into the vein, it's going whatever you want to call this, into the tissue around here. This is called where it infiltrated into the local tissue. The medical term is extravasation. All nurses are required with every single patient that has an IV to assess the IV site. So you always assess an IV site prior to administering a patient a medication through that IV site. You're always going to check it. Plus, that's a standard part of shift change, is to check all the IV sites, make sure they're patent. Patent is the word, that they are intact, they are good to go. Next we have, and you're going to learn a lot more about extravasation. Some medications, it's not a big deal if it infiltrates, other than the fact that that doesn't count as the patient got the medication, so you're still going to need to give it to them. But usually it's not harmful to that local tissue. Some medications, it can be very harmful to that local tissue, whether it's the AC, whether it's the hand, whatever area it is, it can be very damaging. And we'll learn more about that as we get to each of those drugs. Next, I want to cover a CVL, or central venous line. This is a method of giving a medication. It's still IV into the vein, but it's a central venous line as opposed to a standard IV, which is known as a peripheral venous line. So a central venous line is placed, this is only done by providers. There are some exceptions. Some nurses can be trained on this, but generally this is the provider doing it. They're putting a central line, they're putting it much deeper access into one of the major veins in the body. And the biggest advantage of these is that it doesn't infiltrate. These don't have that risk. The other big advantage to this is that if the medication is toxic to the local area, like potassium, which can be painful as it's infusing, this can sort of mitigate that because we're sending it straight into a much bigger IV where it gets diluted right away within our blood. The tremendous downside to this is a risk of infection. You may have heard about central line associated infections known as CLABSIs. Or you may have also heard the fact that these are complicated to insert and they have a lot of risks with insertion. So those are the two downsides and the two upsides to using a CVL. Now let's go through a bunch of terminology that you're going to have to learn about in pharmacology, in addition to the actual drug names, which can be hard enough to pronounce. Let's start. Drug and medication are interchangeable terms. You can use either one. Some textbooks prefer one, some prefer the other. A prescription refers to any provider order, not just to medication. So a doctor can give or a nurse practitioner can give a prescription for a patient to be on bed rest. They can give a prescription to get the patient's vitals every 4 hours. Those are all counted as prescriptions in the healthcare world. I know in the outside world, we do count prescriptions as referring only to medications, and even more specifically, only to medications that are not available over the counter. We're going to talk more about that in a few minutes. Pharmacotherapeutics is where we use medications for improving our health. So we get therapy through pharmacology. Pharmacokinetics is how medications move through the body. Some medications will go much more in depth than others about how they move through the body. Again, we're going to keep this lecture to an RN level. At the NP or MD level, you might get more into this, but we are definitely going to talk a lot about that. Pharmacodynamics is the way a drug affects the body, and a lot of times that will be in the drug class name, and we're going to learn much more about that. But pharmacodynamics, the mechanism of action, is also closely related to pharmacodynamics, but it's what does the drug do that gets us the desirable outcome. Pharmacogenomics is a study of how a person's genetic makeup affects their response to medication. So some patients have different genetic factors, and that can actually change the way medications are absorbed to them. The famous example of this is the fact that CYP450, we're going to talk about at the very end of this lecture, is at a different level in patients of an Asian descent as most other descents. So there's some genetic factors in pharmacology. That's what pharmacogenomics studies. Mechanism of action is what a drug does that leads to the desired effect, very closely related to pharmacodynamics. Next, we have the trade or brand name, what the company markets the drug as. So the classic example would be Tylenol or Advil. Those are the trade or brand names. Next, we have the generic name. That is the name that we're actually going to use in healthcare. So for Tylenol, it's acetaminophen. For Advil, it's going to be ibuprofen. We only use generic names in healthcare. On your NCLEX, on any other test you're going to take, it's always going to be generic names only, for the simple reason being that trade and brand names, there could be changing. There can be lots of them. For example, ibuprofen is both Advil and Motrin. And so we don't want to have to study so much extra, so we do keep it to generic names. That being said, in this lecture series, we're always going to mention both generic names and brand names because I want you to learn both of them, because patients really only know the brand name, and in the healthcare system, we only use the generic name. Well, as nurses, you're in between. You're in the healthcare system, but you're dealing with patients. So you really do need to know both. But again, if you're only going to learn one, it has to be the generic names for testing purposes. Next, we have a combination drug. This is a single pill or solution that contains multiple medications. A classic example of this is going to be NyQuil. NyQuil is medication, is the brand name, and it contains in it, it has doxylamine, it has acetaminophen, it has other things with it. So it's an example of a single pill or solution that contains multiple medications. Next, we have drug class. This is the most common classification of drugs. So I want to be a little bit clear here. There's something called therapeutic class. Therapeutic class is such as antidepressants, anti-epileptics, antihypertensives. So what does that mean? A therapeutic class is all the drugs that treat this problem. Antihypertensive would be every drug that treats blood pressure. Anti-epileptic would be every drug that treats seizure. Antidepressant would be every drug that treats depression. A drug class is more specific than that. So let's say within antihypertensives, you're going to have your ACE inhibitors, you're going to have your angiotensin receptor blockers, you're going to have diuretics. Those are drug classes. So let's use the example of a beta blocker. A beta blocker could fall under an antihypertensive because it is an antihypertensive drug. That would be the therapeutic class, but the drug class is beta blocker. Now, most drugs, I'd say probably about 70%, and I'm making that number up, but that's my best guess. Most drug classes are very closely linked, if not the exact same thing, as the mechanism of action. For example, beta blockers. Beta blocker is the class of drugs. How does it work? What's the MOA, the mechanism of action, which, by the way, you're going to learn the MOA for every single drug we go through, unless there are a few exceptions to that because we just don't know how it works. We just know that it works. But the MOA of beta blockers is that it blocks beta. That's how it gets its effect. So you're going to have to know that. Most drugs within a single drug class, for example, beta blockers, are going to be the same. So a patient is almost never going to be on two drugs in the same class. I'm sure there are exceptions to that. I can't even think of any right now. A patient is hardly ever going to be on two drugs within the same class. Why? Because a drug in the same class are, for all intents and purposes, the same thing. So for beta blockers, we have labetalol or atenolol. There's no reason in the world to be on both. If you want to get more beta blocker effect, give a higher dose of a single one. There's no benefit in the world to giving a second one in the same class. Generally, for testing purposes, especially the NCLEX, what order would the nurse question if the nurse sees that a patient is getting two drugs within the same class? So if they're on two ACE inhibitors, two beta blockers, two NSAIDs like ibuprofen and naproxen, those are both over the counter. One's a Aleve, one's Advil. If a patient's on both of those, that makes no sense. Next, we have over-the-counter drugs. Over-the-counter drugs are drugs that are FDA approved. They are deemed safe by the FDA for the public to make decisions on when to take the medication. So the whole concept of drugs being versus behind the counter, which is known as by prescription, or being over the counter, such as Tylenol, is what does the FDA feel is the best case for the patient? Do they feel that if we give it to the patient, they might be making their own decisions if they don't have enough information to do that, and it could have bad outcomes? Or do we feel that this medication is relatively safe for the public, and even if they screw up, it's not that big of a deal? That's how the FDA makes their decisions. Plus, they also factor in if we put this behind the counter, let's say a headache medication, how much benefit is that they have to go to the doctor, get a prescription, go to the pharmacy, get their medication, all for a headache? A, that's just making their headache worse, especially today's healthcare. And B, by the time they do all that, their headache could possibly be gone already. So you didn't give them that proper balance of weighing the risk of putting that medication out there for the public versus the benefit of someone having that medication available right now when I have a headache. So for that reason, a bunch of medications are over the counter where the FDA feels that patients can take it on their own. They're not that powerful. They're not that likely to screw it up. And there's that much benefit in having it available right away versus the FDA, the Food and Drug Administration, if I haven't said that already, is going to make most medications behind the counter by prescription so that the public gets the doctor or the nurse practitioner making an informed decision based on the massive amount of pharmacology that they have to know and that you're about to learn in order to know if that is appropriate for that patient. It's medications that the FDA feels patients are much better off letting the doctor, the NP, make that decision. And I'm going to keep saying doctor and NP. I'm not leaving out PAs. It's just too much of a mouthful to add them in there too. Next, over-the-counter medications in the hospital are still by prescription only. Remember, in the hospital, everything's by prescription. So there's no such thing as a patient in bed 3 or 4 complaining of a headache. And you're like, oh, sure, I'll just get you some Tylenol. Doesn't work that way. In the hospital, it has to be by prescription. That being said, you may have a standing order for it. We'll talk about that later. Onset is how quickly a medication takes effect. So the example of acetaminophen, Tylenol, usually if you take that, within 30 to 60 minutes, the medication takes effect. And that's the rule of thumb for all PO medications. 30 to 60 minutes, they take effect. As opposed to IV medications, the rule of thumb is all IV medications begin to work within 5 to 15 minutes. Next, we have duration. That's how long the medication lasts. We have indications, what the medication is used for. So every drug that we're going to learn the indication. So if I'm giving a patient nitroglycerin, what is nitroglycerin used for? Well, it's used for angina. It's used for chest pain. Those are the indications. If I'm giving a patient acetaminophen, what is it used for? It is indicated for a fever. It is indicated for pain, for analgesia, which means pain relief, and it's indicated for general cold and flu symptoms. So those are 3 indications for that medication. First pass or first pass effect, as some books say, is a reduction of the medication by the liver for medications taken enterally. So the first pass effect, first of all, for testing purposes, it only applies to medications taken PO or some other way through the GI system, meaning it's going through the stomach. Because when we take medicine in through the stomach, in order for it to get fully absorbed into the bloodstream, it has to go through the liver, because the liver filters out what comes into our body through our stomach or through our mouth, then our stomach. But the liver is responsible for filtering anything that came in through our mouth before it gets to the bloodstream. If I gave it directly into the bloodstream or IM or sub-Q, this doesn't happen. But if I took it PO, then it went to the stomach, and in order for it to get to the bloodstream, which is where most medications have to go in order to have their effect, it has to go through the liver. That's called the first pass effect. The most important thing to know about the first pass effect, in addition to that it is only applicable to PO medications, is the fact that the first pass effect will dramatically knock down the amount of a drug that's available. So for example, if I give a patient 5 milligrams of Valium, that's a sedative. If I give a patient 5 milligrams of Valium, that's known as diazepam, that's the generic name. If I give them 5 milligrams of diazepam IV, that is going to be roughly the same effect, and I'm using very rough numbers here, that's going to be roughly the same effect, if not more, than giving the patient 30 milligrams of PO diazepam or Valium. If I give it PO, I'd have to give 5+ times more to get the equivalent dose. And why? Because the first pass effect is going to wipe out or going to knock down or destroy a ton of that medication, only letting a little bit through. That's a big part of the first pass effect that's commonly tested on. So hopefully you now understand that. If not, go back or reach out for questions. Next, we have the blood-brain barrier. This is a barrier that literally sits in our blood vessels at the cranial level between the rest of the body and the brain. And what does it do? It makes it so that some substances that are free-floating in our blood throughout the rest of our body, we still don't let them go up to the brain. The brain is super extra protected. It's super vital and critical. Even if something is okay to run around in the rest of the body, it's not okay to run around in the brain. That's what we have the blood-brain barrier for. And that's its purpose, is to keep certain chemicals away from the brain. That being said, if we want to give a medication and we want it to work on the brain and get up into the brain, we have to consider the fact that it has to be able to get through the blood-brain barrier. Next, we have excretion. This is the way medications are eliminated through the body. By far, the absolute most common method of getting rid of medications in the body is through the kidneys. The kidneys pee out the vast majority of all medications. That's critically important to know, because any patient that has poor kidney function is almost always going to need a lower dose of the medication. Why? Because if I give you a standard dose of, I'm making up a drug, 500 milligrams, and the kidneys can't get rid of it like they're supposed to, then 6 hours later, when I'm supposed to give you the next 500 milligrams, your kidneys haven't gotten rid of the last one yet. So now I'm just building up the medication to a toxic level. Therefore, if a patient doesn't have proper kidney function, almost always we're going to decrease the dose. In fact, if you look up proper dosing for most adult medications, you'll see the standard dose, and then you'll see a dose for a patient that has decreased kidney function. Next, we have metabolism. Metabolism, or your book might call it biosynthesis, of a drug is done primarily by the liver, and that is the actual breakdown, the metabolism of the medication. Half-life is how long until the medication level drops in half. So if, let's say, I take a dose of acetaminophen and the medication level works when, or the medication gets to a peak level in my blood of 500 milligrams, whatever. So if it gets to 500, how long until it drops to 250? That's half-life. How long until the medication level drops in half? This is very interesting because this ties directly into duration. Duration, we learned, is how long a drug works. Almost always, I hate using the word almost always, it's poor English, but anyways, in the vast majority of cases, when a medication reaches its half-life, when the drug level drops in half, that's usually when the duration ends, when the medication is no longer effective in the body. Loading dose, when a large dose is given to quickly bring the patient to therapeutic level. The classic example of this is a Z-Pak. A Z-Pak is an antibiotic, azithromycin. If any of you have ever taken it, it's one of the most common antibiotics. And this one, the medication is taken the first day a double dose, 500 milligrams, and then on subsequent days you take 250. That's a classic example of a loading dose. The other classic example, if you work in a hospital setting, is TPA, which is what we give for strokes and in rare cases for a heart attack. That medication also, we give a large loading dose, and then we give the patient what's called a maintenance dose. A maintenance dose is the loading dose already got you up to the drug level that we want. Now we just want to maintain it. Next, we have potency. That's how strong a medication is, versus efficacy is how effective a medication is. Which one would you prefer, the strongest medication or the most effective? The correct answer, hopefully, is the most effective medication. Why? Because that's going to be the most effective at treating my pain. I don't need the strongest medication. That might be too strong. I want a medication that is most effective for me. The most potent and the most effective are not always going to be the same. Next, we have agonist. An agonist activates. Just remember that. An agonist activates. So an agonist, when a medication stimulates the effects of a receptor or a substance, versus the opposite of an agonist is an antagonist. An antagonist is when a medication inhibits the effects of a receptor or a substance. When we talk about antagonists, you're going to see a few different words for this throughout pharmacology. You're going to see beta blockers, or you're going to see beta antagonists, or you're going to see beta inhibitors. For example, I've never seen beta inhibitors, but you will see it called beta blockers, and you will see it called beta antagonists. And inhibitors would just be a third word. They all mean the same thing. Antagonists, blockers, or inhibitors all mean the same thing. It's that they block the medication. An example would be of inhibitors would be statins. Statins are HMG-CoA reductase inhibitors. Next, off-label use. Every medication that is officially legal to sell in the United States as a medication is always going to be officially labeled for XYZ. Classic example would be trazodone. Trazodone is a medication that is FDA approved to treat depression. However, once the FDA approves a medication and it's legal to buy it and sell it in the United States, or to make it available to pharmacies by prescription in the United States, at that point, providers do have some leeway, some flexibility in how they use that medication. However, this must be done with patient consent. Back to our example of trazodone. Trazodone is a medication. It's an antidepressant. It's officially approved by the FDA to treat depression. However, trazodone has a massive side effect of making people tired and making them fall asleep. So if a patient has insomnia and they have difficulty falling asleep, this medication works great. This medication, trazodone, is more often used to treat insomnia than it's used to treat depression. Every time it's used to treat insomnia, that is called an off-label use. The label does not say it's for insomnia. The label says it's for depression. I'm giving it to a patient not for depression, but for insomnia, which is off the label. That's not on the label of what I'm supposed to be using it for. That is called an off-label use. Off-label use is a much bigger discussion once you become a prescriber, if you go on to the NP or MD level. However, off-label medications, it is up to the provider to use that as long as they can back up what they're doing, why they're doing it, and that the patient is properly educated and consenting to going ahead and doing it. In real life, we do this all the time. That being said, we do it all the time in specific medications, like the example of trazodone. But other times it would be completely inappropriate. If I'm giving you a beta blocker for pain relief for your stubbed toe, that's completely inappropriate. That would be called off-label, but that would also be called malpractice. Next, we have taper. Taper is to slowly come off of a medication. So if a patient was taking 40 milligrams a day of prednisone, we get them to 30, 20, 10, 5. That's called taper. The opposite of taper is titrate, where we slowly go up on a medication. If you're taking prednisone, which is a steroid, which we do always taper and titrate, that one, if we go from 5 to 10 to 20 to 40, that's where we slowly titrate, we go up on a medication. A more classic example of that is with epinephrine and norepinephrine. When a patient's doing poorly in the ICU and we add a very powerful medication to bring up their heart rate and blood pressure, these are always tapered and titrated in order to maintain a certain level of hemodynamics, and we'll learn a ton about that coming up. Next, we have NKDA, no known drug allergies. This is where the patient has no allergies to any medications. NKA means no allergies, period, anything whatsoever. So NKA includes NKDA, and that NKA would only be appropriate if a patient has no allergies. NKDA would be appropriate if a patient has no allergies to drugs, but they are allergic to pollen or Band-Aids or strawberries. Those would all be appropriate answers there. Next, we have refractory. Refractory is when a patient does not respond to medication or treatment. So, for example, the lingo you might hear with this is a patient's blood pressure is low, refractory to 2 liters of saline. What does that mean? Their blood pressure is low, refractory. It didn't respond to 2 liters of saline, meaning I already gave them 2 liters of saline. Black box warning. A black box warning is the highest level alert that a medication will say on the label, like cigarettes famously say, Surgeon General's warning. A black box warning is the highest level warning that the FDA can require a manufacturer to put on their drug about XYZ. For example, beta blockers have a black box warning that if you're taking it long term, you shouldn't suddenly stop taking it. And that is the highest level warning, and you'll learn why. But it's a big deal if a patient's been on a beta blocker for a long time and now they suddenly stop taking it. So a black box warning is the highest level of alert that a medication can carry, alerting the provider or the prescriber that this medication XYZ about it. Next, consideration. A consideration is also an alert that a medication is written, but it's a consideration. Just consider it. I'm not saying you can't do it or can't do it. I'm just saying consider XYZ. That's a consideration. And then we have contraindication. Contraindication is a no-go. If a medication is contraindicated, you cannot give it. If a patient is high on cocaine, you cannot give them a beta blocker. That is contraindicated. So again, contraindication is a no-go. Consideration is think before you do. Black box warning is really think before you do, and honestly, you probably shouldn't be doing it. Next, we have MDV or multi-dose vial. This is a vial that has more than one medication, more than one dose of a medication in it. These are relatively common, but not nearly as common as single-dose vials or SDV. SDV or single-dose vial is the vast majority. If I'm grabbing morphine or Zofran or tons of other drugs out of the Pyxis, which is the medication machine, if I'm getting it out of there, almost always it's going to be a single-dose vial. There are many examples, though, of MDV's multi-dose vial. One common example is going to be insulin. And again, that's a vial that has more than one dose. It is critically important that nurses really check what they're doing with these vials, because it is very easy to give the patient way too much or way too little, as opposed to a standard dose or a standard single dose vial where generally you're just drawing up the whole vial and you're good. Next, we have minimum effective concentration. This is the lowest concentration where a medication is effective. So if I take acetaminophen, Tylenol, when the medication hits some level in my blood and my headache starts to go away, that's the minimum effective concentration. When it gets way above that, it can hit toxic concentration, and that's where it starts to have harmful effects on me. And the area in between, the minimum where it starts to help and toxic where it starts to hurt, is called the therapeutic range. There are two other terms I want to make sure you're familiar with. I've seen these in a few different textbooks and a few different test banks on pharmacology: peak and trough. Peak is the highest that level of medication gets in the body, and trough is the lowest level. And we use this a little bit scientifically when we're trying to figure out how a patient's doing on a medication. We check their peak and trough level. What's the highest the medication level goes? What's the lowest? And if I check their medication level, let's say every 2 hours over the next 24 hours, the machine can tell me the highest the medication level got was this was the peak, and this was the trough. And it tells me if I'm in the right range of where I'm supposed to be. Next, we have a reversal agent, also known as an antidote. This is probably self-explanatory. This is a medication that's given to counteract the effects of another medication or of some harmful substance or poison. So we do have lots of reversal agents. The most famous one by far is Narcan, which is naloxone. That's meant to reverse what? Opioids. Good. And that in many states is available over the counter. Next, we have a side effect. Side effect is something that happens from taking a medication, but generally speaking, it's not a big deal. An example of a side effect would be if a patient gets nauseous from taking a medication or gets a headache from taking a medication. Those would be side effects. There are known issues with the medication, but they're generally manageable, as opposed to an adverse effect. An adverse effect is a side effect, but it's a step further. It's not just something that is known to happen and that happens because of a medication, but it's something that we won't tolerate. Classic example is lisinopril. Lisinopril is a medication. It's an ACE inhibitor used for high blood pressure and other things, but it is known to cause a cough. Okay, so a cough is a side effect in most patients. However, it can also cause angioedema. Angioedema is facial swelling. That would definitely be an adverse effect that would get us to stop the medication. I should go back and clarify. In a cough, some patients that's considered tolerable, some patients it's not. And again, we always provide a holistic approach based on what the patient says is tolerable to them. I don't think you should ever have a test question unless it's super obvious. Pick which one of these is a side effect, which one of these is an adverse effect. We wouldn't really split hairs like that, again, unless it's really obvious. A headache or nausea or upset stomach would all be side effects, versus an adverse effect would be a widespread rash, or swelling, or widespread swelling, or something else that's a major issue. Next, we have tolerance. Tolerance is when a set dose has decreased efficacy due to previous exposure. What does that mean? If, let's say, I'm used to dealing with something over and over and over again, I build up a tolerance. I'm able to tolerate it. Well, in pharmacology world, the classic example is an opioid. If every day I take 5 milligrams of Vicodin, like Dr. House, and one day the 5 milligrams of Vicodin just don't work as well anymore. So now I got to go up to 10 and 15 and 20, and it just keeps going. That's called a tolerance. Next, let's talk about CAMs. CAMs are complementary and alternative medications. These are substances that are taken for health that are not regulated by the Food and Drug Administration. I'll give you some examples, and a fun activity you can do is try to come up with any more examples, because there's over 100 different CAMs out there. Echinacea for cold and flu, chamomile for anxiety, insomnia, and other. I'm not going to go through this whole list, but there are tons of them. These are just examples. However, a lot of these will be tested on in pharmacology, so you will have to know these. I put 5 of the more common ones, but there are probably about 10 or 15 that I do see frequently coming up in test banks. Again, your school or in your textbook will go over the ones that they feel you should know. With these CAMs, a few things you have to know. First of all, you must inform the patient. This is included as a medication. They need to inform their doctor. They need to keep their chart up to date on what CAMs they are taking. Every time I see a patient, I'm always asking them, what medications are you taking, what over-the-counter are you taking, and what herbal and other substances are you taking. This is included in their medication reconciliation, their med list. Additionally, please educate your patients to make sure they're buying these from reputable sources. Because it's not regulated by the FDA, it's a free-for-all. They could buy it online, they could buy it in store. There's a lot more options for this, and some are more reputable than others. Please educate patients on safety to make sure they're getting it from a proper place. Next, let's go through some pharmacology principles. The 6 rights of medication administration. I assume most schools, by the time you got to this class, you've already seen it at least once, but let's go through it real quick. Patient, medication, time, dose, route, and documentation. What does that mean? Every time I give a drug, I'm checking to make sure I got the right patient. I'm checking I have the right medication. I'm checking it's the right time to give it. I'm checking that I'm giving the right dose. I'm checking that I'm giving the right route. I spelled route there wrong, so I'll have to fix that, but checking to make sure I give the right route, and checking to make sure that I document appropriately. Those are the 6 rights. These are no wiggle room. You will always check all 6 rights before giving it. If you don't and you screw one up, there's no way you are getting out of that because you did not check the 6 rights. Next, if a medication error occurs, and these do happen, if a medication error occurs, the first thing, and you're going to see this on your tests, and you could see this on the NCLEX, the first thing you do is assess your patient right away, then immediately report it to the provider and to your charge nurse. But the first thing you're going to do is assess your patient. Next, pharmacoeconomics is being considerate of costs in prescribing medications. A good example of this is if, let's say, a medication comes in a combo pill. Let's say it's lisinopril and hydrochlorothiazide. Those do come together. Separately, they're each about $10, but if I get them together, it's about $250. So it makes much more sense to get them together. By the way, there are examples where it's the opposite. Because of the convenience of 2 pills, it's going to be more expensive to get the 2 pills together versus separately, they're cheaper. Again, pharmacoeconomics is being cost effective with your money, with your medication. Factors of absorption. You may see this a lot on tests. This is a tremendous topic, but there's a lot to go into. I'm really going to just brief over it. But factors of absorption is what impacts the standard way of a medication being absorbed in the body. So if I take a pill and I take that into my body, what can impact that medication working like it's supposed to? What are the factors of absorption? So one example is having a really low blood pressure. If I have a really low blood pressure and you put a medication into my IV, if my blood's not really flowing, the medication's never going to get where it needs to go. Another factor is how I give it. If I give it into a patient, into their abdomen, into the subcutaneous tissue, and they have a ton of subcutaneous tissue, it might take a little bit to get to the blood vessels. So there's a lot of different factors of absorption. There's too many to go into in depth in this video, but I just want to teach you what that means. Another rule of pharmacology is that the more doses per day a patient is supposed to take, the lower the compliance. So once a day is the gold standard. We love it when a pill is just once a day. Patients do really well with that. Twice a day is usually okay. Once we get into 3 or 4 times a day, that's considered a disadvantage to prescribing that medication to most patients. Obviously, a lot of people are really on top of their health. They're really good with this. It's not an issue, but we do in healthcare consider that when a drug gets to 3 or 4 times per day, that we start to see a decrease in compliance. And again, you may see that on tests as a legitimate question. Next, we have medications that can be coded. What does this mean? Medications can be either enteric-coated, sustained release, or extended release. The first thing you have to know about these three terms, enteric-coated, sustained release, or extended release, is that none of these can be crushed up. Very often, you're going to be crushing up medications to give it to the patient. Let's say a patient's supposed to get some a medication, you crush it up and you give it into a spoonful of applesauce, you give it to the patient, and the patient does well with that. None of these medications are able to be crushed up. I do want to mention one point about that. Whenever you are crushing a patient's medication up, if you're putting it into, let's say, applesauce, and you're doing it into one of those 4-ounce containers, dump out half the container before you mix the medication in. Because we really want the medication mixed into the smallest amount possible, maybe just 2 or 3 spoonfuls, because if it's into the whole container and the patient takes a few bites and they're done with it, they don't want to finish it, how much medication did the patient get? We have no idea. Did you mix it perfectly that if they got half the applesauce and they got half the medication? Probably not. So that gets us into some problems. So just a rule of thumb, if you are mixing medication, ice cream into applesauce, whatever it is, please do it into just 1 or 2 tablespoons so that we don't run into issues. Back to where we were. When a patient is taking these medications, they cannot be crushed. Next, what are the purpose of these medications? Enteric-coated, a classic example is aspirin or some other NSAIDs. These are coated to protect the stomach from the drug because the stomach can be harmed by this medication. Other times, it can be to protect the drug from the stomach, like sustained release and extended release. We don't want the stomach to break down the drugs. We want to protect the drug from the stomach. Those are enteric-coated, sustained release, and extended release. Next, parameters. Many orders will have parameters. Parameters are guidelines that can change the original order. So, for example, give digoxin, but withhold if the heart rate's less than 60. Give lisinopril, but withhold if the systolic is less than 90. First of all, if you're giving these medications, excuse me, you have to make sure, obviously, you're assessing vitals before you give it, which we're always assessing patients before we give it. But we also have to make sure that we are following the parameters, because if the patient's systolic, in this case, was below 90 and you gave the medication, you just gave a medication you had no permission to give. Considering the parameter was written for a reason, you probably hurt the patient too, but you for sure practiced medicine without a license by giving a medication that you had no prescription for. Because if that parameter says not to give it, then you did not have a valid prescription to give it, and you're going to end up in really bad place. Next, a valid medication order must include the following: the patient's name, the drug name, the dose, the route, and the time. The time might just say stat or one time or now or something like that, but it does have to have all of those. If it's missing any of those, it is not a valid prescription. Next, best practices in pharmacology. First and foremost, as an RN, or if you're watching this as an LPN or an NP student, know that first, that the most common cause of healthcare errors is medications, period. No question about it. Most common cause is not the doctor missing the diagnosis or the surgeon messing up in surgery. The most common cause is med errors. It happens way too often. Next, medications that require vital signs must be assessed at the time you're giving the drug. If it's 9 a.m., there's no way you have an excuse to use your 7 a.m. vitals from 2 hours ago. You have to use the medications, the assessment at the time of administration. Plus, if you are assessing vital signs, this is just me talking, not your textbook. If you have to assess, let's say, a patient's blood pressure before giving medication, don't just check the blood pressure, check all the vitals. It's a good habit to get into. Next, every medication must include an assessment and a reassessment. Before you give the medication, what do you check? You check the condition you're treating. If I'm treating a headache, I'm going to evaluate their headache. If I'm treating nausea, I'm going to evaluate their nausea. I'm going to verify allergies, and I'm going to check for any contraindications. So, for example, you're going to see this a ton on your future exams in pharmacology. For which of the following patients do you need to assess the BUN or creatinine before giving the drug? Those are 2 kidney labs, and those would be for drugs that are damaging to the kidneys. So prior assessment, prior to administration, would be assess what you're treating. If it's a headache, how's the headache? Assess that there's no allergies, and assess if there's any contraindications. And then after you give a medication, after you give it, you're always going to reassess what you're treating. How is your headache now? How's your nausea now? Plus, you're going to assess if the patient's having any side or adverse effect. Generally, just ask them, are you having any side effects from the medication? You don't have to go into, are you having a headache? Are you having nausea? Are you having dizziness? Are you having vomiting? Just ask them, are you having any issues with the medication? Next, when you're treating a patient, and I'm going to use the classic example of pain, always include non-pharmacological interventions. Those are always appropriate. A nurse can do them on their own authority. You don't need a prescription for that. and it's always going to be included. Even if the patient's getting morphine or fentanyl or some really strong medication, we're still going to give them non-pharmacological interventions for pain relief. I assume at this point you've already learned that in another class, but non-pharm interventions for pain relief includes things like lowering the lights, changing the bed sheets, putting on a TV, putting on music, talking to the patient, guided imagery, and so much more. Now, it doesn't just only work for pain. There's non-pharm interventions for insomnia, like making the room cooler, making the room darker. Those are for insomnia. Or quieter. There's non-pharm interventions for constipation. Give the patient more fluid. Give the patient more fiber. So lots and lots of different symptoms or signs can have non-pharm interventions, and these should always be included in what the nurse is doing, and you're always expected to include this for testing purposes. Next, most IV medications are packaged as one vial, one dose. It's called a SDV, a single dose vial. We talked about that. But what I want to point out here is that if a patient is getting a dose that you're having to grab 2 vials or 3 vials, please always double check what you're doing. It could be you're right. If a patient got ordered a double dose of Zofran, it's going to be 2 vials, 8 milligrams. That's appropriate. We do that. But please get in the habit, if you're grabbing more than 1 vial to give the dose that the provider ordered, please double check it. Make sure you're doing the right thing. Next, always ensure that patients are educated on what they are being treated for. The best way to ensure a patient takes their medication is for them to understand why they need to take their medication, not just because the doctor said so. So in order to improve compliance, and this is a fear test question, how do we improve compliance? Through education. Next, always assess your patient if there's any change in condition. Anytime, especially on test taking or in real life, if a patient, you suddenly notice that there's been a change, they say, my chest is hurting me. That's an obvious one. But even if you're just looking at the heart rate, you see it's been 80 for the last 10, every time you looked at it, and all of a sudden it's 105, please go reassess your patient. When a patient comes in that a medication is not working, always ask them, tell me, how are you taking the medication? Don't say, are you taking it like you're supposed to? Ask them, tell me how you're taking the medication. Next, learn priorities of when to immediately assess versus taking an action versus notifying the provider. And the classic example here is if a patient develops an allergic reaction, what's the first thing you're going to do? If it's an IV medication, the first step is discontinue that IV. It's a common test question. If it's a PO medication, the first step is assess your patient. And then once you've done that, then the next one might be notifying the provider. But you're not going to jump and notify the provider before taking an immediate corrective action, such as discontinuing or stopping an IV, or taking an immediate assessment of the patient before notifying the provider so that you can let them know what's going on. Don't just run out there saying, hey, I need help. Go assess your patient, then go out and say, hey, I just noticed a change in condition. Here's my assessment. Please come help. Next, let's talk about controlled substances. And we're getting to the end of the video. I know this is a long one. I'm going to try to keep future lectures broken down into smaller pieces. The list of controlled substances are the list of drugs that are high risk for abuse and dependency. These are divided into 5 classes, and they're regulated by the DEA, the Drug Enforcement Agency. These are all still approved medications by the FDA, but then they're regulated by the DEA. And this is per the United States Controlled Substances Act of 1970. I've seen that in some test banks. That's why I'm putting that on there, but you do need to know that. So let's go through the different schedules. Schedule 1 is a medication that has no approved use whatsoever and is highly addictive, highly abused, and you can become highly dependent on it. The drugs in this list are heroin, marijuana, LSD, PCP, and so much more. Yes, marijuana is on this list. Yes, it is very well known that it's much safer than that and that it's approved at many state levels. However, at the federal level, as of when this is being filmed in the middle of 2025, marijuana is still considered a Schedule 1 controlled substance, meaning it has no approved uses whatsoever. Next, we have Schedule 2. Schedule 2 is the highest risk of abuse and dependency, but it does still have some legitimate medical uses, and that includes fentanyl, morphine, hydromorphone, and more. Next, we have Schedule 3. This is where you have your amphetamines. This is where you have phenobarbital and a few others. Schedule 4, these are relatively low risk of abuse. This is where you have benzos and sedatives. We use that a lot for panic attacks and sleeping medications. And then we have Schedule 5, that's the lowest risk of abuse and dependency. That's medications like Tylenol with codeine, things like that have a very low risk of dependency. Now, I want to first clarify, the term narcotics is not really used in healthcare. We use the term controlled substances. We use the term benzos and opioids. We don't really use narcotics. That's more of a law enforcement term. However, drugs can be a controlled substance, whether or not they are what we classically think of as the narcotics, because something like steroids, certain types of anabolic steroids are regulated under the Controlled Substances Act. And even though those are completely not drugs that we think of as narcotics, so it doesn't necessarily mean that it's not a controlled substance. Every one of these medications, you need to educate your patient on abuse and dependency. However, if it is appropriately prescribed, please educate your nurse. If the doctor ordered this, don't be worried about addiction. Go ahead and take this so that we can get you the relief that this medication is designed to give you. Also, almost every single one of these does have a black box warning for abuse and dependency. I say almost, but I'm pretty sure it's all of them. Next, finally, we're getting to the last two sections. Let's talk about lifespan considerations. Pediatrics, in infants, they have an underdeveloped blood-brain barrier. So in that patient, they may have a medication that really can harm the brain, but it gets up to the brain because that blood-brain barrier doesn't exist yet. It's not really that relevant to you as an RN because you're not prescribing. However, I do see that on a lot of test banks, and it is in your textbook, all of them. So do make sure you know that. Next, medications in pediatrics of all ages are more likely to be weight-based dosing than the standard adult size dosing. When we are prescribing medications to children, always educate the parents or whoever their patient is with, the child is with, on safe storage of the medications that it can't get to the child. Do not refer to medication as candy in order to get the child to take it, because even though that might help today, in the future, that might make the child go for the medication again, thinking it's candy when it's not their medication. There's a lot of tragic stories over history about that. Next, do not mix a medication for a child with juice or milk, because then if it messes up the taste of the juice or milk, the child may never want juice or milk again, and those are generally considered healthy beverages for children. Next, let's talk about pregnancy for a little bit. You're going to see a ton about pregnancy as we go through different drug classes. The FDA has moved away from using the pregnancy categories A, B, C, D, X. That's what it used for a long, long time. Certainly that's what it was when I started healthcare, but as of about 6-7 years ago, I think it was 2018, the FDA disbanded that. It no longer requires every drug to be labeled A, B, C, D, X. Now it just gives us information. This drug has been shown in some cases to cause X, Y, Z. This drug has been shown to be safe in all cases of pregnancy. It gives us some more verbal information instead of just a letter A, B, C, D, X, because it's a more fluid situation. And there's a lot of cases where drugs used to be considered an X. And the classic example of that is a statin. Statin is one of the top 10 most used drugs in the United States. It's a medication for high cholesterol, which unfortunately most of this, or a ton of this country has. And because it was labeled as an X, it was an absolute no-go for females who were pregnant. However, as of, I think, 2021 or 2022, the FDA came out and said, actually, the risk versus reward says that maybe you should be on it, and it's up to the provider and the patient to make a joint decision. Why? Because they found that coming off of your statin, again, if you're in that case where you have such high cholesterol that you need to be on medication, especially if you're still young and at a childbearing age, and you're at that point and you still need the statin, then you probably need the statin. And coming off of it can be even more harmful than the risk of continuing it to the pregnancy. So again, we no longer categorize things as A, B, C, D, X. You may still see them, but that's all old information. The NCLEX will definitely not use it. Now we use a decision process based on information between the provider and the patient. We do still have medications that we use the term teratogenic, and you're for sure going to see that on probably every pharm test you take. Teratogenic means this should not be taken in pregnancy. Teratogenic means that this medication has been shown as harmful to the patient. Some medications are still clearly considered teratogenic. Some medications are considered mildly teratogenic. And again, that would be a little bit beyond the RN level, but you would certainly see on a pharm exam which of the following drugs is considered teratogenic. Next, let's move on to geriatric patients. The first and foremost thing you have to know about them is the risk of polypharmacy. Polypharmacy is where a patient's taking multiple medications. If a patient is taking multiple medications, then that does present a challenge to us to make sure that they don't mess up, because the more medications they're taking, the more likely there is to be an honest error between the providers, between the prescribers, between the pharmacy, and obviously the patient themselves in what they're supposed to take. So it is our job to do what we can to mitigate it. The trays that now say Sunday, Monday, Tuesday, Wednesday is a really good thing. There's lots of other pill pack by Amazon, something that gives each patient the individual medication. Each dose is packaged together to make sure they're taking each thing correctly. There's been a lot of innovations and improvements in this, so that's becoming less of an issue, but it's definitely something you're still going to encounter as an RN. It's certainly something you're still going to see on your exams. Next, if a patient is geriatric, we do have to look out for decreased renal or hepatic function. And like we talked about a half hour ago, that these medications do sometimes require a dose change very often. And finally, geriatric patients may have increased sensitivity to certain medications, so we definitely have to take that into consideration. And those, you will learn about them as they come along. It's nothing that I'm going to get into in a fundamentals introduction video. Lastly, I'm going to talk about CYP450. I'm going to talk very briefly about this, even though this could be an entire lecture by itself. This wasn't really taught at the RN level when I went through school, but it is taught now today, and I've even seen it on some test pages. So cytochrome P450 or CYP450 is a group of enzymes that are responsible for the metabolism of many different drugs. So because of that, if a medication is involved, or CYP450 is involved in the metabolism of your medication, then we have to do a few things. First of all, one of the cytochromes within the CYP450 is called CYP3A4. This is involved in the metabolism of roughly half of all drugs, and grapefruit juice inhibits this enzyme. So because of that, the medication won't be able to be metabolized. That's why, if you haven't already heard, grapefruit juice is one of the most commonly known issues or foods or liquids to avoid with medications. Roughly half of all drugs should not be taken with grapefruit juice, and this is why. It's because of one of the CYP450 enzymes that, or I don't know if these are enzymes, but they are, but one of the CYP450 enzymes that are able to impact the metabolism of the medication is why we have other points that we teach about. Also, CYP450 is different in patients with Asian descent than a lot of other ethnicities. So this is also something that is becoming more and more of an issue and more taught at the RN level. I don't really want to go any further into it than that. I don't think your school will, but just know in general, CYP450, it's an enzyme. It's responsible for the metabolism of drugs. It can alter the drug's metabolism. It's why we don't take grapefruit juice, and it's an issue in tons of different drugs. If you want to know more about that, I'm sure your textbook has a whole lot more. If you guys have any questions, please feel free to reach out to Bullet Point Nursing. Please subscribe to our channel and like our video. Have a great day.